Welcome to ModPath Chat, the official podcast of modern pathology, featuring interviews with authors and experts on the latest science, technology, and developments in the field of pathology. Our host, Dr. George Netto, is the editor-in-chief of Modern Pathology and professor and chair of pathology and laboratory medicine at Perelman School of Medicine at the University of Pennsylvania. Here's Dr. Netto.
Welcome to ModPath Chat. My guest today is Dr. Nicolas Poté, Associate Professor of Pathology at the Université Paris Cité, Paris, France. He's also an attending at the Department of Pathology at Beaujon Hospital. Dr. Poté is an expert in hepatopathology with a special interest in understanding the molecular biology of liver tumors, which is going to be the topic of our discussion today. We will be discussing his team's recent publication, and by the way, senior author is his boss, Professor Valérie Paradis, on proposing a practical diagnostic approach for borderline hepatocellular adenomas. So thank you, Nicolas, for accepting my invitation and showing up from Paris via Zoom.
Thank you, George. Thank you.
So I really liked your study. I'm a closet hepatocellular interest. In my past, I used to dabble with that topic before I became a geopathologist. So clearly this study grabbed my attention, and I wanted us to discuss to our audience the great analysis that you did and see how that can be of practical significance for us. So tell me first why you did the study. What's the issue at hand in terms of background? I'm not sure everybody's familiar with borderline hepatocellular adenoma. If you can enlighten us.
Yes, of course. So thank you for the invitation and the opportunity to present this paper. So, as you know, hepatocellular adenomas are rare benign liver tumors that occur mainly in women taking oral contraception. And these tumors are considered as prenoplastic lesions because they are at risk of malignant transformation into hepatocellular carcinoma. About 4% of hepatocellular adenoma can transformed into HCC. Mm-hmm. And main risk factors are male sex, large tumor size, and a mutation of gene of beta-catenin, particularly in exon 3. And so the molecular alteration associated with malignant transformation of hepatocellular carcinoma have been well studied by the team of Jessica Zuckman Rossi, which is a molecular biologist in Paris. And the malignant transformation is characterized by two main alterations, so mutation on exon 3 of beta-catenin as a first step, and followed by TERT promoter mutation to promote full malignant transformation of hepatocellular carcinoma. And in a subset of hepatocellular adenoma, about 5 to 7%, they present some morphological feature of HCC, such as a loss of reticulin frameworks, pseudoexternal architecture, cytological atypias. But these features are focally present and insufficient for a definitive diagnosis of HCC. So
yes. Just to stop you there. So the morphologic features are atypia and loss of reticulin, but is there the 5% cutoff is critical?
Yes. There are no consensus on the cutoff for these features, and in the literature, these tumors are designed by various terminologies. Some call them borderline hepatocellular adenoma, some others atypical hepatocellular neoplasm, and others well-differentiated neoplasm with uncertain malignant potentials. So, but there are no consensual definition of these tumors, but the cutoff of 5% of this feature in the whole tumor is the most accepted criteria. Yes.
And that's what we used in the study.
Yes. These borderline hepatocellular carcinoma are challenging for the pathologists, but also for the clinicians, because pathologists for the diagnosis, because we don't know if we can classify them as hepatocellular adenoma with atypia, or are there early HCC or HCC, very well differentiated HCC. So for pathologists, it's a challenging lesion, particularly on biopsy samples. So the aim of the study, was to compare the clinicopathologic and molecular feature of borderline hepatocellular adenoma with those of typical hepatocellular adenoma with no atypia, hepatocellular with obvious malignant transformation, and also a group of HCC to assess to classify them and to assess the risk of malignancy.
Perfect. So thank you for this synopsis. So basically, in this study, you're trying to compare, let's for the sake of the study, use the borderline, and I understand similar to ovarian at certain time and many other organs, there's so many terminologies for these borderline. But so you're comparing the borderline to the ones that don't have any atypia, so we'll call these the typical adenomas, to the ones that already have hepatocellular carcinoma originating in a background of adenoma, and then to the bona fide hepatocellular carcinoma. So tell me a little bit then about the cohort, and just briefly about the techniques that you used, so we can move on to the findings and what's next.
Okay, so this was a retrospective study. When we included 106 liver resection specimens from 2 reference centers, so Beaujon Hospital in Clichy, France, and Mondor Hospital in Créteil, France. And all tumors that were initially diagnosed as atypical hepatocellular carcinoma, borderline HCA, or difficult to diagnose between HCA and HCC were included. So we reviewed all the tumors with 2 liver pathologists, so myself and Professor Valérie Paradis, and the tumors were classified as typical hepatocellular adenoma with no architectural or cytological atypia, HCC, according to the WHO classification, hepatocellular carcinoma developed on hepatocellular adenoma, so it was obvious foci of HCC within an hepatocellular adenoma. And borderline hepatocellular adenomas were defined as hepatocellular adenoma with cytological or architectural atypia, covering less than 5% of the whole tumors, and focal loss of reticulin also. On this cohort, we did molecular analysis on 93 tumors in fresh frozen samples. So we did gene sequencing. So these were genes associated with molecular classification of hepatocellular adenoma, such as HNF1 alpha, beta-catenin, IL-6, and also the promoter of TERT. And we did also on this sample transcriptome analysis with 96 panel genes by reverse transcription qPCR. And we also did analyzed the TERT promoter mutation in formalin fixed paraffin embedded samples in 44 cases by a Sanger analysis.
Excellent. And also you did a couple of immunohistochemical stains, including beta-catenin, right?
Yes, and also immunochemistry to classify the subtype of hepatocellular adenoma, inflammatory, HNF1, hepatocellular adenoma, beta-catenin, etc.
Perfect. So it's basically very comprehensive, somatic mutation, gene expression array, gene expression signature, and immunohistochemistry, and the genes of interest for the mutations were HNF1A, catenin, and GNAS, JAK1, and STAT3, and of course TERT promoter, as we just mentioned. So what were the findings, and in terms of differences, especially in the molecular, between the four categories, I guess, that we had there?
Yes. So we included in total 42 typical adenomas, 39 borderline hepatocellular adenomas, 12 HCC developed on HCA, and 13 HCC. So interestingly, borderline hepatocellular adenoma shared some clinical feature with the typical hepatocellular adenoma. Many patients were female, about 70%, young female, so with a median age of 37 years. And most of the tumors were single nodules. And regarding molecular subtypes of HCA, borderline hepatocellular adenoma were mainly beta-catenin mutated hepatocellular adenoma. 41% of beta-catenin exon 3 mutation. So those are at risk of malignant transformation. And also a few subset of exon 7 and 8 mutation of beta-catenin. And interestingly, also 5 cases, so 13% of sonic hedgehog hepatocellular adenoma were classified as a borderline. So that's for the clinical and the molecular subtypes of borderline adenoma.
Excellent. So, as far as outcome, I mean, these patients were resected, right?
Yes, interestingly, for patients with available follow-up, about 50% of patients in our cohort, there were no tumor recurrence in all these patients, in 20 patients with borderline hepatocellular adenoma, compared with 40% of recurrence in the group of HCC on HCA.
So if you had an HCC developed in an adenoma that grew, they had significant recurrence, as opposed to the one with the borderline, none of them had recurrence.
Yes.
Knowing that you have a lengthy follow-up on the ones you have, but your follow-up is not on every, and that you mentioned that in the limitations of the study, that not every patient had follow-up, but you had some lengthy follow-up on the ones you did, which seems reassuring that these things really are not aggressive. So
yes, with a median follow-up of more than 1,000 days. So that's
years, over 3 years. Excellent. And but then you put all this together. So I noticed that you mentioned molecularly, and you implied that in what you just said, that they seem to be closer overall. They seem to be closer to typical adenoma, or just adenoma, as opposed to the other end of the spectrum, which is cancer originating in adenoma. Correct?
Yes. Yes. Regarding molecular data, when we did on gene expression a principal component analysis, so no unsupervised analysis, we observed that these borderline hepatocellular adenoma were between typical adenoma and HCC developed on adenoma. So there was how do you say
continuum,
an overlap. So this is in favor of a molecular continuum of this lesion from typical to borderline to HCC developed on adenoma.
Excellent.
But there was no overlap between borderline adenoma and HCC. The two groups were clearly separated on a gene expression analysis. And more interestingly, there was no TERT promoter mutation in all the borderline adenoma, compared to about that was 44% of HCC developed on HCA had a TERT promoter mutation, and 38% of HCC were TERT promoter mutated.
Yeah. So that's very important point. I want to highlight it for the audience that those adenomas that had HCC develop in them, 42% had TERT promoter mutation, somewhat similar to just regular bona fide hepatocellular carcinomas of 38% TERT, and which moves us to which is a good point to mention the great algorithm that you highlight in the paper, and I want the audience to really look at that, and if you can share with me that simplified algorithm that really combine these findings and give us a guidance how to deal with these lesions.
Yes. So based on these results, we propose a decision algorithm for borderline HCA on biopsy samples, and when when the pathologist has an hepatocellular adenoma on the biopsy with atypia, this can be a borderline hepatocellular carcinoma. So we recommend we suggest to analyze beta-catenin activation. So with routine tools such as glutamine synthetase immunostaining or beta-catenin immunostaining. In case of beta-catenin activation by immunochemistry, which is a synonym of mutation of exon 3 of beta-catenin, so the international recommendation recommend to do surgical resection of these lesions. So we stop here for this group. If there is no beta-catenin activation on immunostaining, we suggest to search for TERT promoter mutation by Sanger analysis or by digital PCR. We did also digital PCR on biopsy samples in the study. This works very well.
On paraffin.
Yes, on paraffin samples. So we can do it in routine samples. So if there is a TERT promoter mutation, this means that hepatocellular adenoma is at high risk of malignant transformation, maybe already an HCC on adenoma. So we recommend a surgical resection. Surgical resection could be recommended in these cases. And if there is no TERT promoter mutation, we suggest to search for other molecular alterations that are involved in the process of malignant transformation, such as TP53 mutation, ARID1A mutation, and also methylation profile, but it's more difficult to apply it in routine.
And it's not available everywhere.
Yes, not available in the lab. So if there are other molecular alterations than TERT promoter mutation, surgical resection could be recommended in these cases. And if there are no other molecular alteration, we suggest to manage these tumors as typical hepatocellular adenoma.
Perfect. Yeah. So to summarize to our audience, the algorithm basically, you start with the morphology. If you think this is a borderline because 5% or less has some atypia or reticulin loss, then first thing is do immunohistochemistry for beta-catenin. I know you mentioned 2 ways of doing that by immunohistochemistry. So then if beta-catenin is activated and positive, these should go to resection because of the risk implied And if they're negative for beta-catenin, you move to the next step, which do TERT promoter. And assuming these are needle biopsies, clearly, or somewhat of a biopsy rather than resection, because that's what the algorithm is for, then you do TERT promoter. And on the paraffin, and if that's positive, again, you go to surgical resection. If it's negative, you try a few other markers like P53 and ARID. And if any of them positive, that's also reflect you back to surgical resection. And if it's negative, you just continue addressing it just like any adenoma without atypia. And then it's the size, and the clinician decide whether it's, risk of hemorrhage and others didn't play there into what you do in terms of resection. That's pretty. I hope this algorithm work and get adopted and get tested in by other groups, because that's pretty concrete, and I like this combination of morphology and molecular. Do you know other people are going to use this? Have you heard other places using this algorithm, or you want to go and propagate it?
No, it's quite new, so I don't heard about other teams that apply this algorithm, but we think it's quite simple algorithm, morphology, as you said, one immunostaining, glutamine synthetase or beta-catenin, and further also TERT promoter mutation analysis, which is feasible on paraffin samples and quite easy and quick. So we think this could be applied in pathology laboratory.
Correct.
Quite easy, yes.
Well, thank you very much. Great study. I look forward to future studies, and I appreciate your coming on today. And I certainly learned a lot, and I'm sure the audience too. And I look forward to future interaction.
Thank you, Rick. Thank you very much for the invitation. It's a pleasure to answer questions of readers. They can send me emails.
Perfect. We'll put your email on the synopsis of the podcast. Wonderful. Thank you very much.
Thank you, George. Thank you.
Any opinions expressed in this podcast are the speaker's own and do not represent the views of Modern Pathology, Elsevier, the University of Pennsylvania, or USCAP. Your ModPath Chat host and scientific director is Dr. George Netto. The producers are Dr. Catherine Ketchum and Carly Hess. Technical direction is provided by Kaminsky Productions. Music by Mitch Neubauer. Thanks to the authors, reviewers, and editors of Modern Pathology for making this podcast possible.